Right.
Well, welcome everyone. We have with us today Dr. Howard Lederman, pediatric immunologist and director of the AT Clinical Center at Johns Hopkins Children's Center, and Brad Margus, founder of the AT Children's Project. I am Jennifer Thornton, executive director of the AT Children's Project, and we're really, really glad that you are all here to join us today, and really glad that Brad and Howard are here to help us navigate what happens next for AT families in the world of COVID with everything opening back up. Brad, would you like to take it away?
I would. So thank you everyone for joining us today. I'm, as you heard, Brad Margus. If you don't know me, more than anything, I'm the father of 4 sons, and 2 of those sons have AT or ataxia-telangiectasia. And happy to have another conversation today. As you know, we had a webinar a little while ago, and it had hundreds of participants from around the world. And that led us to organize this additional webinar. As of this moment, we have 68 participants joining us that may climb during this conversation. I think I should mention before we get started that we're finding this webinar approach to be very popular among AT families and community, donors, volunteers, everyone. And so we're thinking about having other ones too besides COVID related. So for example, we may have a webinar on just reviewing for people, particularly families who are new to AT, reviewing how researchers have approached this disease, trying to find a treatment or cure, what significant scientific, clinical, regulatory, and financial obstacles are holding us back, preventing us from making more rapid progress. We may have a webinar on clinical trials that are either underway now or soon to be underway, not just with ASOs that you've heard a lot about, but also nutraceuticals, the steroid trial, some mitochondrial approaches. Many of you received an email from me recently about biomarkers. We may tell people about that. And we also have this global AT family data platform, an international platform that's now about to begin generating and collecting a lot more data from families around the world. We'd love to have a webinar about that. So if you have interest in any of these things, please let us know. We can get a read for how much popularity each of those topics would have. And then we can schedule some things with not only Dr. Lederman, but other experts that we can have join. So on that note, we're now going to introduce again Dr. Howard Lederman from Johns Hopkins. He leads our AT Clinical Center there and has seen hundreds and hundreds of AT kids and adults over the years, many of them returning again and again, so we could get an idea on how the disease affects people over time. He's the director of the immunodeficiency clinic at Hopkins. He's also a professor of pediatrics. So I think before we really jump into the questions about COVID and AT again, we should ask you, Dr. Lederman, a little bit about you. I think people need to learn a little bit more about you. So for starters, you're an MD and a PhD. So that means you're a doctor and also you're supposed to be a scientist, right? A researcher. So you got into this, and I know you went and got those degrees at the University of Michigan, but just to let us learn a little more about you, can you just tell us, were you always like this? Did you, as an 8-year-old, see yourself being an expert on immune problems, and how did you end up thinking about AT?
Well, to make a long story very short, actually in the 4th grade, I wrote a silly little 6-sentence essay that for some reason my father saved. It was on that kind of paper where you have the solid lines and the dotted lines for the capital and the low letters. And I said when I grew up, I wanted to be a baby doctor and I wanted to take care of kids with bad infections. So I don't know if that was exactly 8, but it was probably close to 8. And wow. I have no idea why my father happened to save that, because he was not a saver kind of person. But when he died, we actually found that and folded up in the safety deposit box. Kind of crazy. Wow. And by the time I got to college, I was pretty clearly interested in microbiology and infectious diseases. And I ended up getting a PhD in microbiology while I was in medical school. and somewhere along the line decided that it would be more interesting to be looking at the effect of infections from the standpoint of the host rather than the germ. And that was what led me to the interest in immunology. And then I did a pediatric internship and residency at Hopkins and went to Toronto for 3 years, where I just focused on immunodeficiency, both in the laboratory and patient care. I came back to Hopkins at the end of 1984 and joined Jerry Winkelstein, who already was there and had an immunodeficiency clinic set up for kids. Pretty soon after I got there, it turned out that there was some interest from colleagues of mine in on the adult side in infectious diseases, and I started seeing adults, and eventually ended up with an appointment in medicine. And I now have this kind of strange pediatric clinic, which has preemies and little babies at one end and 93-year-olds at the other end. And I'm really hoping to get to 100. The 93-year-old came in to see me a couple months ago and was limping, and I asked him what happened, and he said he stood on a chair to change a light bulb and he fell off. And I told him he wasn't allowed to do that anymore because he was the one I was counting on to hit 100. And then I guess how I got interested in AT was because of Brad and maybe an accident. So in the mid 1990s, right around the time that the gene had been discovered, Brad was interested in trying to set up a clinical center someplace that would get experience in dealing with large numbers of AT patients instead of 4 or 5 or 6. And we were lucky enough to be one of the people that he talked to, and that the AT Children's Project eventually funded. And we're now, I don't know, almost 25 years later.
Cool. Okay, so let's dive into some of the questions that we've gotten since the last webinar. I think that the thing that people are most curious about is as the world continues to evolve and change, and we, frankly, a month or two ago thought we were getting, in the U.S. at least, a handle on things, and we were starting to open up again. But now we're hearing that a lot of places are actually having significant increases in cases, and maybe it's too late to somehow keep most of the country from COVID, and infections are really spreading. And then in other countries, there are countries that are only now starting to surge. So and we have to keep in mind a lot of people in this webinar are from other countries. But as this happens, the question we have is, what is it safe to do with our families to protect our kids with AT? And there are two parts to this. The first is we hear a lot of guidance from the world and a lot of good sources for what to do, and wearing masks and things like that. But what is different about having a family who has at least 1 or 2 children with AT? Should we be changing in our minds what we hear? Should we be more cautious? What is it that we have to worry about or not worry about? And then maybe we can talk about some of the more detailed things, like about going back to school, about whether having our kids out in the world could not only infect them and be at risk, but also bring having anybody in our family go out in the world could bring back infections to us. I know there are a lot of questions about that, but for starters, can you just talk more generally about how AT kids are they different and at more risk than other people with COVID, like elderly people or people who are generally poor health, maybe obese or have diabetes, or they vape and smoke or whatever? We know those people are at risk, but how do AT kids stand?
All right, so like everything else about AT, there's not a simple answer that fits everybody. There is a tremendous range of kids and adults with AT. So, and the other thing is that there is virtually or maybe absolutely no data, because I have yet to hear of anybody with AT who's gotten a confirmed case of COVID-19. So a lot of this is going to be hand waving and best guess estimates, but it's not based on any data. And that's the most important thing everybody should know. So what I would say is, in trying to estimate the risk that a specific person with AT may have for COVID-19, I think you have to think about a couple important points. The first one is whether that person has immunodeficiency. So there are a lot of people that with AT that don't seem to have any increased susceptibility to infection and don't seem to have any major problems with any laboratory tests. There are small numbers who have significant problems with immune deficiency. I would say the biggest indicators of that are going to be somebody who's unable to make antibody and is on gamma globulin therapy. Another one, a little bit less solid, but another one might be the person with AT who's got clusters and clusters of warts, which might indicate a problem with the way their T cells can handle at least some infections. So I think if you are in a category where you're either on gamma globulin or you have lots of warts or some other strange infections, that would make me a little bit, that would put that person at a little bit more risk than a typical person with AT at the same age. The other big determinant I think that would make me nervous is either significant lung disease from previous infections or maybe some chronic inflammatory process, or some of the older AT patients that just have a hard time getting air in and out and having an effective cough. So I think somebody with AT who was 28 and otherwise healthy, but had difficulty with a big, deep, clearing kind of a cough, might be somebody that I would be a little concerned about if they got COVID-19.
And what about like body weight? If an AT kid or adult is particularly thin, would that make you more worried? Does that affect how strong or resilient they are if they do get COVID?
Well, I think any of the kind of general health issues are going to be important. So being thin by itself, I think, is not a problem. Being thin to the point of seeing every rib and having weakness from undernutrition might be an additional risk factor. We know that that's an additional risk factor for getting through almost any kind of stress or any kind of infection. And then you have the usual risk factors that affect the general population. So somebody who had diabetes that was poorly controlled. There are not very many, but we have had a few people with AT over the years that have really been obese. And I think that's the same risk factor in somebody with AT as anybody else. We think that hypertension is probably a risk. So I think any kind of chronic infection or chronic condition, not infection, but chronic condition other than AT would be the kind of thing that would make me a little bit more nervous.
Is there anything that we should be doing with our AT kids to be more prepared if it happens and if that they get infected or get sick and we have to take them to an emergency room, for example, monitoring their vital statistics, their blood pressure, their pulse, that's something we might want to keep track of now so that you know what's baseline or normal when you get sick? Or is there anything nutritionally we should be doing now, just beyond what we normally do, just to prepare? Is anything we can do?
I would say if anybody is really borderline nutrition, that this is a good time to try to get some extra calories in. And it may be a little bit easier because kids are not in school, they're at home. And so it's a little easier to feed them when they're home all day than when they go off to school for X number of hours. But I certainly don't think you're going to be pushing calories to the point of getting somebody stuffed either. So I would say rather than, I don't think there's any need to be checking blood pressures or oxygen saturations or anything like that. I don't think that's going to be helpful at all. What I would say is everybody should be familiar with the signs and symptoms of a SARS-CoV-2 infection. And if you have somebody in the family, AT or not, who has fever, who has cough, who has muscle aches, who loses a sense of smell or taste, that probably the most important thing to do would be to get that person tested early. So if it turns out it may not be the person with AT in the family, it could be that it's it's an adult that's going to work who wakes up one morning feeling achy and has a low-grade fever, maybe a cough. I think it'd be really important to be proactive and get that person tested as soon as possible, so that if there's COVID in the house, you can get that person isolated and try to limit or decrease the chance that there's going to be spread to anybody else in the home.
And in the meantime, while they're being tested, you don't always get fast turnaround, contrary to what sounds like you're supposed to. So if it's a few days to get a result, should we quarantine that family member in the meantime?
Yeah, I think anytime you're suspicious of COVID-19, that's the safest thing to do.
Yeah.
So that's probably the biggest issue. I think most of the people with AT are staying home, and when they're going out, they're relatively limited in contact with other people. So the biggest risk is probably the person in the house or the people in the house that are going out to get groceries, the people that are going out to work, and so I think having them monitor their condition and being proactive and not denying symptoms for a couple days is probably the most important kind of preparation that people can take.
Okay, so now can we ask you this? So we've all been in hiding. We've been, well, a lot of our companies have either limited our jobs or made us work from home, and we've all been together, and that has its own challenges sometimes of us living too close to each other for too long. But all in all, there have been some good positive sides. A lot of us have seen our kids a lot more. It's great. But now, let's say the kids are still at home, but at least one parent, or maybe both parents, but at least one parent now has to return to work as their place of employment opens. When that person goes and being careful, they're in an environment with people who could be.
You're fading in and out now, Brad. All right, I'm going to guess that what Brad is trying to ask before he was frozen is that what are the precautions that the person should take if they're the one going out to work? And what I would say is that the majority of time, COVID is transmitted from a prolonged contact with somebody who's infected. And it's a prolonged contact with somebody who's relatively close. So all the usual precautions that you're hearing about in every newspaper and every TV commentary really hold. So wearing a mask, keeping social distancing of 6 feet or more, and being really careful about hand washing. So I will tell you that in the hospital, on a typical day, if I wash my hands 200 times, that may be an understatement, because I'm trying to be really careful that if I get anything, that I don't get anything, because I don't want to spread it from one patient to another, and I don't want to bring it home to my family. So I think by the time I get up to my office in the morning, having hit elevator buttons with my elbow or whatever, but I still have to touch a couple doorknobs. Once I get into my office, I Purell my hands. And whenever I leave my office and go somewhere else, I'm Purelling my hands. I personally think that that gloves are not a good idea.
So everybody around the world knows what Purell is?
Yeah, well, some kind of a disinfectant. So it could be an alcohol-based disinfectant that you rub on. It could be soap and water with a really like a 30-minute scrub with soap and water. But hand washing is really critical. And I think actually one of the parts of the mask that's most useful is that if you happen to forget to wash your hands, you still can't get your hands on your face very easily. For people who don't wear glasses, you have to remember that rubbing your eye is just as good as putting your finger in your mouth. And that's the one kind of advantage, I guess, that people have if they wear glasses, because it's an extra kind of barrier between their hands and a mucous membrane, which is the part of the face that's at risk. So anything that looks like the lining of your mouth, the inside of your nose, the inside of your mouth, the white part of your eyes, those are all the areas that are going to be easily infected. There is no reason at all that somebody ought to be coming home and then forced to strip in the garage and run naked through the house to shower. That makes no sense. I don't think there is any good data on transmission from the outside of a pizza box or a cereal box or can from the grocery store. And when a person comes home from grocery shopping, no reason that you need to take every item out of the bag and spray it with alcohol before it comes in the house. Again, I think if you're going to go grocery shopping, you go grocery shopping wearing a mask. I think every grocery store these days has some kind of a disinfectant that they spray on the handle of the cart and that you can put on your hands. But just carry a bottle of some alcohol-based sanitizer with you. Wipe your hands, wipe the handle of the cart, go about your business and get your groceries. And, before you start handling the doorknobs of your car, use that Purell again. Open your car, put the groceries in, and then go home.
So why are you worried about the car handle but not the box of food you just bought, or that somebody else touched and pushed across the conveyor belt in the grocery store that 1,000 other people's hand touched things across? And why are you worried about some surfaces, not others?
I guess the only reason for worrying about the car handle is that after you've loaded the car with everything and then you go back to your door, if you contaminated that at the beginning when you unlocked your car, then you contaminate your hands again. And when you get in your car, I don't know about you, but I know the first thing I do is take my mask off because I've had it with that mask. So if I've contaminated my hands immediately on the door handle and then I happen to rub my face, that may be a risk. Maybe overkill.
When you take off that mask, where do you put it down that it has COVID on the outside of it?
I usually just detach the top part and I let the other part just hang onto my shirt. Unless somebody has really coughed or sneezed right in your face, I don't think your mask is contaminated.
So the big thing that a lot of us parents are thinking about is if we have a kid either who has ATN and some immune deficiency, they need gamma globulin, or they have warts, or they are older and they have weak lungs, right? People we've talked to have said that they're going to really, really suffer and have a hard time with COVID. So we don't want them to get infected no matter what. And a lot of the guidelines that people have are significantly reduce your risk of getting COVID. That's great. But that's different than really not wanting a kid to have any chance of getting it. That's the dilemma a lot of us have it's different for one of us. We would take the chance, okay, it dramatically reduces our chance of getting it. And then there's even a much lower chance that if we got it, that it would be hard on us, especially if you're young. So that's different than trying everything you can to eliminate the risk completely, in which case a lot of us say, okay, there isn't a lot of data of people being infected from surfaces, but there are publications now of the virus sitting on surfaces for quite a while and lasting there. A lot of things just still aren't known very well. We had a period when everyone told us not to wear masks, and now everyone tells you to wear masks. So who knows what else people will learn. So we're kind of in this extra heightened, almost fearful state. And that's the dilemma we find ourselves in. What do you say about that?
Well, again, there's not a right answer, and everybody has to find a place that they're comfortable with. I personally think that if you want to take a family of 4 and move to a cave and seal it up and have somebody drop your groceries off every 2 weeks and sanitize everything before the groceries get in, you may not get COVID, but you're likely to go crazy. And there has to be some kind of a middle ground. So I will tell you as an example, I am not of the opinion that going to a restaurant with outdoor seating is something that I want to do, whether or not my local community says that it's fine. On the other hand, if there's another family that I think is being as careful as I am about social distancing and masking and minimizing outside contacts, then we have had another couple come over to our backyard and had dinner together with them, with the 2 families on either end of a 6-foot table. I think that the chance of transmission in that kind of a setting, with everybody healthy and everybody taking precautions, is extraordinarily small, especially if you're living in a community at the time where the transmission rate is low. And this is a little bit like saying, you don't want to die in a car accident, so you never get in a car. And it's true, if you never get in a car, you'll never be in a car accident. But I think most people would probably say that that's being overcautious.
How about, I'd like to ask one question about school, which is the most common question I think we're being asked. If you have someone with AT who's in that higher risk AT group, should their siblings return to school in the fall if schools are open?
So that's a really tough question. And I think that is going to be very dependent on what things look like at the end of August or the beginning of September. And I really hesitate to make much of a prediction at the end of June. Everything about this virus has changed and changed and changed again. I think a lot of that decision will be based on, number one, what is the prevalence of disease in your community. It's not even in your state, but in your local community, how much active disease is there. So I can tell you that I've looked at my stepdaughter and her family in Rockland County in New York, and there have been something like 6 new cases on average per day in that county for the last 3 or 4 weeks. So I think that county right now has a very low transmission rate. And if the transmission rate was that low and schools made a decision to open with appropriate ways of having social distancing and masking, then I think that's probably reasonable. Now, again, it depends a little bit on who are the kids that are going to school. So if you have high school kids or middle schoolers, and they're serious knowing about the risks of their brother or sister at home, and you think they're really going to be careful about wearing a mask, and let's say the school is going to be on some kind of a system where class size is half of the usual and everybody is apart, and there's no communal dining in the lunchroom, that's probably fine. If a couple of the siblings are 3 or 4 or 5, I think that's a much riskier situation because 3, 4, 5-year-olds, no matter what their intentions are, don't ever keep their hands out of their mouths, and they're always bumping into everybody else, and they share toys. And I honestly don't see any good way that they're really going to be socially distant the way an older child or an adult would be. So I think this is really very situational dependent. And you have to look at the prevalence in the community. You have to look at exactly what the schools are doing. And you have to look at the age of the kids that are going to be going to school. Okay. I have to say, I think that the schools and the government are going to be very risk averse in the current environment. And I suspect that that schools are going to be very conservative in opening. I doubt that very many places are going to be liberal about it. And I think the experience with the kind of easing up of restrictions and the surge in cases is going to guide that.
Great. Let me ask you a question about treatment. So, just with regular individuals, not AT, in general public, if you develop COVID and you're not in a trial, but just you get COVID and you're in an emergency room or intensive care, at some point there's a list of things that they try on you, and I think some of them are antiviral, some of them are anticoagulants because there's some clots that develop, and then steroids is also common, and so as an immunologist, it'd be helpful for you to tell us, steroids are used anyway when someone's got an inflammatory response going on in distress, and they throw steroids at it, hoping to make the person recover or fight the battle better. I'm asking this because a lot of the families that are on this webinar right now actually have participated in one of the several steroid trials that have been done for AT. And those were done with a different purpose, ideally that the steroid would somehow help with neurological conditions too. But in general, do you think that steroids are only something that you do once you have COVID? Is there any chance that steroids could help an AT kid, the kids who are in the trial, for example, could be more resilient against the virus? Well, talk a little bit, please, about this role of steroids and all this, what we should think about that.
All right, so I'm going to back up a little bit and give what I think is maybe a larger context for this. So the way I think about SARS-CoV-2 and how it causes this disease, COVID-19, is that you have an initial infection in the nose. The virus replicates, it gets from there into the lung, probably gets into other tissues as well, and it causes a pneumonia. At the very beginning, all of us will have what's called an innate immune response to a virus. So this is nothing that requires previous exposure or immunity. It's kind of a general way that the body recognizes that there's a virus and a variety of different host defense mechanisms that come into play immediately. And that's probably really important in limiting the severity of this disease and limiting the severity of the infection right from the beginning. That is a part of the immune system that, as far as we would predict, is probably normal in most people with AT. Once the lungs get infected, then the process of cleaning up the virus and getting rid of the infection depends on a combination of T lymphocytes and natural killer cells. The natural killer cells in AT should be completely normal in terms of function, and they are virtually always in completely normal numbers, and I would expect that should be working just fine. The T cells, usually those are lower numbers than normal if you have AT, although in most people that low number doesn't seem to be a terrible clinical problem. In both of those first two stages, I think steroids are not likely to be helpful, and high doses of steroids may actually be detrimental. So steroids will kind of decrease that initial non-specific inflammatory response, and steroids may decrease the T cell response in the second phase when you're trying to get over the virus. The only data that really support the use of steroids in this infection is in people who get to the third stage. So that's where they don't recover in a kind of a typical way from the lung disease, but the lung disease takes on a kind of a different feel. It's not so much the virus replication and the virus infection, but there is an overactive response from the patient, and they create this tremendous exaggerated inflammatory response. And that's what usually is required for people to get to the point of being in an intensive care unit with really severe lung disease, and probably very important for getting people to the point of being on a ventilator. And that's the point where if steroids have a role, it'll be usyou So I certainly don't think.
Can I just, so let me reiterate that, and then you can tell me if we get it or not. So early on, when you first get the virus, you need your inflammatory response. You want to have your immune system react to it, and so you don't really want to dampen that by getting steroids. And only if you're at the very later stages when things are out of control and really severe problems with the lungs, at that point, maybe steroids can help. Is that right? And
that's 100% right.
Okay, and so if you've been in taking steroids for any reason, low dose steroids as part of a trial or whatever reason, just as a healthy AT kid, that's not likely to be a good thing to help you fight off COVID.
Well, so I think the low dose steroids are probably not going to have much effect one way or the other. Right. So I don't think any of the steroid trials that have been going on, or the Aridel trial that's going on right now as an example, is going to give enough steroid to damage or weaken the immune response in the first two stages. And I certainly wouldn't start a patient with AT who has a newly diagnosed COVID-19 infection. I would not just start them on steroids at that point. I would treat them the same way that I would anybody else and not give them steroids unless they were one of the small minority that progressed with severe lung disease.
Okay, can we just jump to a topic you brought up last time that many of us found really intriguing, and that was convalescent plasma treatment. So maybe for anyone who doesn't remember, or for people who weren't on the last webinar, can you briefly just explain what it is? Then can you tell us if anything more has been learned by the world about whether this approach helps at all in COVID? And then the last thing, if you could just tell us, update us or tell us about the possibility of trying it in AT kids, but maybe start in that order.
Okay, so convalescent plasma is the liquid part of the blood that's collected from a normal person who gets COVID-19 and recovers completely. And in the process of doing that, they will make antibody. And people are tested, and if they have a high concentration of antibody in their blood, then they are selected as a volunteer, and they can give a unit of plasma. And we still don't really have solid data from the large double-blind big trial that's going on that's looking at trying to decide or trying to tell whether this convalescent plasma works or not.
So just to be clear, plasma is just like your blood with some other stuff removed from it, right?
Yeah, plasma is the liquid part of the blood. So it's the part of the blood without the red cells, without the white cells, without the platelets. It's just the liquid part.
But it still has the antibodies floating around.
But it has antibodies in it. Okay. It's a little bit like gamma globulin, except to make gamma globulin, we get rid of everything else in the liquid except the IgG. So this is going to have a lot of other blood proteins that we all have in normal amounts. Okay, so there are data from a number of other respiratory tract infections. See a number of infections for measles, for chickenpox, for a viral infection called RSV. That's probably where the data is the best. That if you give people antibody either before there's infection or you give people antibody right at the very beginning, that you can decrease the severity of infection. Now, that's for other diseases, but not for COVID-19. So the idea behind this would be that if we had somebody at high risk and they had a close exposure, so in this particular case, let's say there's a parent who got sick, was definitely diagnosed with COVID-19, and one of the children has AT, that child, depending on what's available locally, might be eligible to get an infusion of convalescent plasma, with the idea that it would either prevent the lung infection or limit the lung infection. Okay, again, there's no data right now to say that that's going to be definitely useful in anybody. There's anecdotal data, and we've had lots and lots of anecdotal data about all kinds of drugs in COVID-19, which turn out not to be worthwhile after we get a big controlled study. I'm expecting that there'll be data sometime this summer, maybe within a month, on a huge trial with comparing convalescent plasma with plasma from just normal uninfected people, and at least in adults with without AT, I think we'll have some good data in 4 to 8 weeks, I suspect, suggesting whether that's helpful.
We will call you in 4 weeks about it.
That's fine. In the meantime, there are drugs that could be used. So there is an antiviral, remdesivir, and it has been shown to be modestly helpful in people in that second and third stage of disease. I would probably say if you have a child with AT who definitely gets COVID-19, that I would try to get remdesivir early on in the course for that child. So in other words,
it'll work in AT just as well in a person without AT, the way it works? Or?
Yeah, that'll work just as well whether you do or you don't have AT.
Cool. Okay, so can we just ask you on kind of a bigger thing? It may not be really AT, but I'd love to hear your opinion on it, and that is just what is your thinking? What does your gut feel say about the likelihood that if you really get it, you don't get it again, or that a vaccine will prevent you from getting it again? As an immunologist and a trained microbiologist, what do you think?
So I would suspect that if you get COVID-19 and you recover from it, that you will be immune, at least for some period of time. I don't know whether you're going to be immune forever, but I would suspect that you will have enough antibody to protect you for a season at least, kind of like what happens with the flu vaccine. It may be that immunity is going to be stronger and last longer than that, but I think we don't know right now. And the same, I think we don't have any idea what's going to happen with a vaccine. But I would suspect that we will be able to come up with a vaccine that is at least moderately effective. It's possible that the vaccine will have to be given every year.
If we had a vaccine available, you would be urging us to have our AT kids get it?
Yeah, all the vaccines that are in trial right now are all killed vaccines. So there is no risk whatsoever in terms of getting the infection from a vaccine.
This killed vaccine.
So it means that there's nothing, there's no live virus in the vaccine. So there's some vaccines, like the measles, mumps, rubella vaccine, is a vaccine that's made from weakened kinds of virus, but the virus is not killed. And in somebody who has a significant immunodeficiency, you could give that vaccine and they might develop a mild case of measles. Most of the vaccines that we get, the injected flu vaccine, the pneumonia vaccine, the tetanus vaccine, those are all made of either germs that have been completely killed or synthetic or purified pieces of a germ, but nothing that's going to cause any possibility of infection. So I'm waiting to see what the data are and to see whether, which of these vaccines seems like it's the most likely to work, and to make sure we have data to say that in normal people, at least, there's no unexpected side effect. But once we have a reasonable candidate vaccine, assuming that I think it's safe for the general population, I can't think of any reason why I wouldn't recommend it for everybody with AT, with the proviso that some people with AT may not respond as well as other individuals.
So most
But
AT
again,
kids
everybody in the family getting immunized is probably as important, because that keeps the chances of getting COVID into the household to a minimum.
So you can certainly get, most AT kids and most families have other vaccines that we've all gotten. Those should all be continued, I assume, even in this environment. But they really don't have any effect on protecting you from COVID, right?
So there's a little,
like the pneumonia vaccines some people have had, not to mention all your childhood vaccines.
Yeah, so there's some suggestion that if you get vaccines to other viruses, that it might induce for a short period of time a kind of a non-specific beneficial effect. But at this point, I would consider that to be theoretical and not anything that's that I would act on. The most important thing, I think, is that this fall everybody needs to get a flu vaccine, and that's for two reasons. One is we don't want to have anybody getting a preventable lower respiratory tract infection, which might make the lungs a little weaker and then more susceptible to the effects of COVID-19. The other one is that influenza and COVID-19 look alike. And if we start having a lot of influenza cases and we still have COVID, we're going to have a lot of people coming into emergency rooms and a lot of people getting quarantined for COVID that probably don't need to be quarantined. And it's going to really create havoc for everybody individually and for the health system overall.
And again, is there anybody that it's not, any AT kid for whom it's not worth getting the vaccine? I mean, or even if you think that you don't make much in antibodies, you should go ahead and do it.
Yeah, I can't think of a reason not to get the injected or killed flu vaccine, whether you're on gamma globulin, whether you're on chemotherapy, no matter what. The worst that'll happen is you get a needle prick and it doesn't work. But even if you can't make antibody, it might stimulate some other part of your immune system and provide some protection to the flu.
Great. And is there anything you would, this is switching now, I need you to wear your psychiatrist hat, but as we talk to our kids about COVID, if you were an AT parent, is there anything, and of course it depends on the age, but anything messaging wise you think we should say? I mean, in our family, we feel like the longer we don't get infected, even if there isn't a absolute treatment or a vaccine yet, each day scientists and physicians are learning a lot more about how to manage it. So every month that goes by, we think we're better off than we were. So that's something we're hopeful about. But is there anything you would say to our kids and to our families?
Well, I would say that for most of us, that influenza is and continues to be a much greater risk. So even with everything going on now, and even with the highest estimate of cases of COVID in the United States, there are many, many, many more, by millions and millions, cases of influenza every year. And influenza can be a really damaging infection in the lung. And we don't keep all of our kids in cocoons, and we don't keep ourselves in this kind of isolation box for influenza. And so there has to be some kind of a balance between what I think is appropriate concern and what I think gets to be almost a paralyzing anxiety. I think if people take reasonable precautions, and I think that means wearing a mask, being really careful about hand hygiene and social distancing, that in that setting, if you're not working in an environment where 30 people are crowded all together around some meat packing machinery, or you're not in a home where you have 3 generations with 14 or 15 people in 3 rooms with 1 bathroom, that still the transmission for any individual is still pretty small. If I don't know exactly what the total number of cases is going to turn out to be in the United States, but to give this into perspective, the total number of right now laboratory confirmed cases is somewhere around 3 or 3.5 million, which makes it about 1% of the population. If you assume that figure is off 5-fold or 10-fold, you're still saying that 90% of the population hasn't been infected. And I think the people that are the highest risk are the people that are living in kind of closed, crowded communities. And I'm not even talking about who are the people that have the hardest time when they get infected, but crowded housing, people that are in very crowded work conditions where the opportunities for distancing and hand hygiene are not so great, are still the people that have the biggest risk. I think for most families, school is going to be right now the biggest unknown and probably the biggest cause of concern. And I'm going to just say we'll have to have another webinar at the end of the summer to figure out where we are then. Okay, for all I know, by the time we get to the end of the summer, there might be a vaccine that is going to be in a trial for people that are at high risk, and I might say, maybe it's worthwhile to try the vaccine. I have no idea.
Great. So I think we have to wrap this up, but I think I'm going to go out on a limb at great risk and say that if someone does have an AT child who's diagnosed with COVID, Dr. Lederman would be happy to hear from you.
Yeah,
100%. Okay.
And my phone number, I think my cell phone number seems to be everywhere. I think we have it on those emergency cards that we pass out.
If not, we will send it to you. So you can certainly reach out to AT Children's.
You can reach out. We can reach out to Jennifer. I don't want people to use a cell phone to call me because they want to know something very specific about some general question. But I think if anybody has somebody in the family who has AT and gets diagnosed with COVID, then you can call me day or night at any point, and I'm happy to talk to the doctor that's helping to manage that case.
Wonderful. Okay, well, I think we're going to wrap this up with one more comment, and that is that I think another part of this COVID is that a lot of us feel isolated and frustrated, and one way we might be able to solve that is to have very small get-togethers online. And so think about any AT families if you haven't seen them in person lately, don't wait. Maybe use Zoom or Teams or everything else there is out there, FaceTime, to have a small happy hour or whatever. We love those things. My AT sons have found them very, very enjoyable. And it's not the same as being in person, but it helps. But again, Dr. Lederman, thank you very much for doing this. We'll take you up on it. We'll have another one pretty soon. We hope the world makes a lot of progress before now in that next one. And as I said at the beginning, also, if you're interested in these webinars for other topics, some of the ones I mentioned, please let us know. Jennifer, you have anything else to say?
That's it. If you have any burning questions that we didn't have a chance to get to, please email me. Plus, we'll be going through the chat thread, and we'll try to be able to disseminate some answers for you. But thank you both very much. Really appreciate it.
Okay.
Thanks,
everybody. Stay safe.